You had a question about this case here. Patients having some grade 2 mobility with number 24 and 25. This was the pre-treatment workup, just to kind of bring us front and center here. Overall, great case for Invisalign, in great part because there's not a whole lot of sagittal correction that needs to be done. In other words, the patient is molar and canine class 1 for the most part. But the bulk of the movement is in the anterior. And that's a great case to employ Invisalign, especially early in your Invisalign trajectory. So these two teeth, you had said the patient's on tray 9, I believe, which isn't that far into treatment. And to have grade 2 mobility this soon could raise a red flag, and that's why you had brought the question to me. So the first thing I want to know is... I just want to kind of follow the path. Where are these teeth going in relation to the existing alveolar housing? And in general, when we're moving teeth towards the bulk or the majority of the alveolar housing, in general, we're safe. In other words, we're moving teeth towards a bulk of bone and not away from a bulk of bone. Just to draw some contrast, if we were to move this tooth buccally for whatever reason, that tooth would be at higher risk for instability, recession, and other unwanted defects compared to these teeth here. That doesn't mean these teeth can't get it, they're just at lower risk. In addition, if we are intruding the teeth, which in this case we are, we're inherently lowering the risk of recession and other issues because we're moving the teeth theoretically in the bone. Theoretically meaning that there's bone apical to the teeth, so that as we intrude them, we're pushing them into bone and not away from the bulk of bone. So from a 10,000 foot view, this looks like a rather predictable movement. But beforehand, what we want to do is we want to say, are these teeth stable to begin with? And looking at Invisalign ClinChecks alone is not enough information for us to say these teeth are good to move. So question 1 would be, was there any bone loss prior to treatment? And if so, did we talk about this to the patient? I know you're taking this case over from another provider, as you had suggested, so you may not have that information. But let this be the lesson that if you see teeth that are extruded like this, which is common with deeper bites or class 2 cases, it might be a good conversation to have. Just looking at the available bone around the teeth pre-treatment and having a conversation with the patient that there might be a risk of mobility and worst case scenario, tooth loss. The other thing I'll often see, and this may be related or not related, when you have overlap like this, when teeth are crowded, as we bring the teeth more buccally, or as we resolve the crowding, we lose bone here. And it's not that we lose bone, it's that there was never any interproximal bone there to begin with. You can picture in your mind's eye that the bulk of this bone right here is actually facial to this tooth here. And as we straighten these teeth, it's not uncommon that you'll actually see dark triangles develop, and radiographically, it'll look like what bone loss occurring, when in reality, it's just reapproximation of the teeth and reapproximation of the interproximal bone that was never there to begin with. So I think that's probably part of it. My guess is there's probably several factors that are leading to this patient's instability. But bring your attention to when there's crowding and the teeth are erupted like this, it's very possible that this root wasn't actually sitting in much bone to begin with. And even though we're intruding and buccalizing, there just wasn't as much as, say, the next person. So that's the first thing. I'm looking at where the movements are going in relation to the alveolar housing. In this case, on the surface, it's fine. I don't think it's related here, but the IPR, I believe, was programmed later on, so we can't really blame any IPR. If we look at staging, yeah, the IPR is being done around tray 15, so I don't really see any issue there. going to the tooth movement table. Just got done playing with the kids this morning, and I'm sure the word poo came out several times. Clicking on lower here, I often want to look at the degree of tooth movement in each different axis. Obviously, these being the different axes of tooth movement. I don't really see a whole lot here. There's no blue dot. The blue dot or black dots indicating that the movements kind of sit outside the norms of predictability. But this is a good thing to take a look at. Honestly, I now just look at this, and after you do enough cases, you get a pretty good sense of what's a lot, too much, and what should be considered higher risk. I don't think I would have put a whole lot of stock into this one, to be honest, unless I saw something on the x-ray. And I'll be the first to admit, I'm not looking at x-rays routinely in these cases. I have, but I'm not sure I would have jumped to that just based on what I'm seeing here. But your question is, what do we do? So patient has grade 2 mobility, 24 and 25. You had a beautiful suggestion of having the patient go to 2 weeks for the next 2 trays. And I think that's a very good approach. After we talked yesterday, I got thinking about the medical legal aspect of this and what would be safest. And I think what would be safest is for us to not stop treatment, but to pause treatment and see if we can regain stability of the teeth. So we're not 100% sure what's causing this, and if we continue to go in a certain direction, we may not be able to regain stability. But if we regain stability now, regardless of where they're at, and then we have a conversation with the patient about what they would like to do moving forward, understanding the risks, at minimum, we at least have a much higher chance of stabilizing the teeth, albeit in a non-aligned position. But we're putting the decision-making into the hands of the patient. And I think that would just be a good idea. So it's in alignment with what you were saying, but I think I'll take it one step further and say we pause in this current tray, keep the patient where they're at. I might even consider splinting them. I think what I would do is have the patient stay in the current tray for a month, bring them back, and if you don't see any decrease in mobility, then I might splint them and put the patient into an Essex and just pause treatment, and then we'll go from there. I've had this happen a lot, so I don't think it's something that we should lose sleep over. But where we don't know with a high degree of certainty exactly what's causing the instability, I feel it's best for me to advise you to kind of slow down and hit pause. And as you're entering Invisalign, the last thing you want is a malpractice case associated with Invisalign because we were getting aggressive. And I know you as a conservative dentist, so I have no doubt you'll be able to hit the pause button here for the patient and just kind of describe what you see on the PA to the patient preoperatively, that she was at higher risk, and but articulating that in a way that doesn't throw the previous provider under the bus will be the delicate part of what you're doing. I'd be happy to kind of kick the tires on the phraseology of that so that we're all working together and not necessarily creating a chasm between treatment recommendations, which patients never love. So I think that's the recommendation. Let me know what your thoughts are. Again, I would approach this case more from a medical legal perspective on what's best versus a scientific perspective. I think science would say, you're fine. I think medical legal wise, it would say, let's hit the pause button. All right, man, keep the cases coming. Looking forward to continuing on your journey with Invisalign and orthodontic therapy. Take care.